think we'll move on to our last study and case that we'll talk about, which is stage 4 EGFR positive lung cancer and the Flaura 2 study. So in this case, we have a 52-year-old female who has a prior pretty minimal smoking history, 5-pack years, who works as a teacher. And then over the past 2 months, she's noted some diplopia, which is double vision, blurry vision, and a sensation of feeling off balance. So something's not quite right. She sees a neurologist and an ophthalmologist, and they both advise that she gets an MRI brain for workup to see what might be going on. So she gets the MRI brain, and what you can see here with these arrows are these spots, these whitish spots here, which are indicative of likely some cancer that is in the brain and most likely spread from somewhere else and gone to the brain. So the next step is sort of figuring out, is this coming from somewhere else, or are these things just starting out in the brain? And so to do that, as part of the workup, a CAT scan is done of the chest, abdomen, and pelvis, or CAP abbreviated here, and it reveals a mass on the right upper lobe of the lung, the ROUL, that's about 2 centimeters, and then it shows some spots in the liver, which also look like metastases, and some bone metastases or osseous metastases. So it looks like cancer has started possibly in the lung and spread to the liver, the bones, and the brain, and the bones specifically in the spine, but no evidence that the spread of the cancer is actually pushing on the spinal cord, so no evidence of cord compression. We need to figure out what this is. And so the next step, as we saw in the other cases, is to biopsy one of these lesions and see what it is. And so the interventional radiologists or IR team gets a biopsy of the liver mass, which is generally one of the easier places to biopsy, certainly a lot easier than the brain. And the pathology comes back showing a non-small cell lung cancer, specifically an adenocarcinoma that seems come from the lung. And so that adenocarcinomas are a type of non-small cell lung cancers. Like we do with all our adenocarcinomas, or we test them for any mutations that we might find. And this testing, a next generation sequencing, testing for mutations reveals, again, similar to the first case, an EGFR mutation, this one in exon 21. This is the L858R mutation, which they found, which is considered a driver mutation. So the EGFR mutations are considered to drive the cancer to grow. And we have developed drugs, as we'll talk about, to specifically attack these mutations. And when we use them, they can control the cancer or cause the cancer to die and stop growing. So now basically what we have here is a patient that unfortunately has a stage 4 metastatic non-small cell lung cancer that is spread to a number of places, including the brain. So I'll ask Dr. Singhi, what would you offer in this case among the choices listed here?
Yeah, I think this is a tough decision. And honestly, you're going to have these shared decision-making conversations with patients. That's also a very big staple in my clinic. When I think about this, I think about sort of 3 different buckets, right? So patient-related factors, disease-related factors, and molecular factors. And we do have some sort of hints or ideas based on some trial data that you're going to present in just a bit here about maybe which way to lean for one patient versus another based on those 3 different categories. I think for most patients, just in general, an option that's still very viable is osimertinib by itself, osimertinib monotherapy. But of course, we're trying to do better to prevent resistance and think about some of these aggressive types of EGFR cancer that really may sort of rear their head in the future and cause a lot of problems for our patients, really cause a detriment in quality of life, really cause a detriment in symptoms that may develop. So these options for combination therapy are also valid. Of course, clinical trial is definitely something that I always discuss with my patients if there's an option that's open and patients are motivated. So I would say any of these are truly fair game, and we're probably going to have a very nice discussion in a bit after some of the data.
Great, thanks. So we'll go on to the actual study that we were going to present, the Flaura 2 trial. So this was a phase 3 international open label trial, which meant that everybody on the trial knew what they were getting. It was the patients were randomly assigned either 1-to-1. All of them had EGFR mutated lung cancers, but specifically these 2 most common types, the EGFR Exon 19 deletions or the L858R mutations. And these represent the vast majority of EGFR mutations that we see. They all had advanced disease, non-small cell lung cancer that had not been previously treated. And they were randomized 1-to-1, like I said, to either get the osimertinib, the EGFR tyrosine kinase inhibitor with chemotherapy, or osimertinib by itself. The osimertinib alone has been a standard of care, or likely the standard of care, at least here in the US, for a while. And the primary endpoint of this study was an investigator-assessed progression-free survival. So based on the treating investigator, at what point did the person on the study progress? So this is the data here with the investigator-assessed progression-free survival. So you can see the red line is the combination of the osimertinib plus chemotherapy, and the blue line is osimertinib alone. And you can see there's a benefit to adding the chemotherapy here with a median progression-free survival of 25.5 months versus 16.7 months with just the osimertinib alone. So that's about a 9-month difference in progression-free survival. So about 9-month median difference in when the cancer starts to grow on the therapy that the patients are on. The hazard ratio here was low, was good at 0.62. And so basically what I try to explain is that at 25.5 months, about 50% of patients that had the combination had not had a growth in their cancer, whereas if they were just getting the osimertinib alone, it was 16.5 months before 50% of the patients had a change in cancer causing considered to be progression. So when you look at sort of which patients benefited the most, they actually pretty much all of them in these categories had a benefit for the most part here. And one of the major benefits you can see is in this subgroup here, which is patients that had CNS metastases. That would mean the spread to of the cancer to the brain or to some central nervous system organ, but generally speaking, the brain. And you can see the further to the left this line is here, where this box is, the more pronounced the benefit is. And that's kind of borne out in this next slide. So if you look specifically at the patients that had CNS metastases like our patient did, so spread of the cancer to the brain, if you looked at those patients, the median progression-free survival was 25 months, roughly, with the combination of the osimertinib and the chemo. But with osimertinib alone, it was only 13.8 months. So there was a very big difference between these two groups if you were only looking at the patients that had metastases to the brain at the beginning to start with. If you looked at those that did not have a metastases to the brain, the difference wasn't as pronounced. Here you saw a difference between 27.6 months for a median progression-free survival versus 21 months. So about a 6-month difference in progression-free survival if you did not have brain metastases when you started. So, we're adding an extra therapy on here. We're adding the chemotherapy. So one of the important things that we've talked about a number of times is toxicity. So you can see here in this graph, osimertinib versus chemotherapy in the orange and osimertinib alone in the blue. And if you look at the percentage of patients with any toxicity, it's relatively the same between the two arms. But if you look at certain toxicities like hematologic toxic effects, which are things like anemia or low white blood cells, which can predispose you to infections, or low platelets, which can predispose you to bleeding, that's higher, a good amount higher with when you add the chemotherapy. And when you look at all events that are grade 3 or some more severe between the two groups, again, it's higher with the combination of osimertinib and chemotherapy. So I'll ask Dr. Prishigal, what do you think about these toxicities, and how does that sort of factor into your decisions between giving osimertinib monotherapy versus osimertinib chemotherapy?
So this is such a tough question because I think we see these patients very often, and we need to think about long-term side effects for them, right? They're going to be on this treatment for life, right? I always say we're going for a marathon, we're not going for a sprint. So whatever we expose you to and whatever toxicity you have to deal with. And I know Dr. Singhi knows this really well. He specializes in seeing patients with young lung, that are young and unfortunately diagnosed with lung cancer. And we have to think, these patients have a lot of life to live. Everyone has a lot of life to live. And we need to think about, how this impacts fertility. We have to think about how does this impact, vaginal dryness or sexual libido or anything of those things, in addition to the things that, you know, we think about with rash and diarrhea. So we have to kind of think about that as a whole when we're looking at our patient. In regards to choosing the right regimen, I don't think we know the right answer. I think if I have somebody, like let's say I'm seeing someone that has an EGFR exon 21 L858R insertion, big bulky disease, you know, brain metastases, that might be somebody that I would say, hey, there's a little bit of data that shows that patients that harbor this specific kind of EGFR alteration with brain metastases may enjoy a little bit more of a benefit with the addition of chemotherapy, but I can't tell you if that's necessarily right. And someone that maybe doesn't have as large of a burden of disease, I might just start with OC alone. But that kind of goes along with the thought of somebody that just has big bulky disease, regardless of exon 19 or exon 21. Sometimes we want to just give these patients a little bit more than OC alone, which is why I always try my best to talk to them about a clinical trial up front that we have here, which is called Shedders, which looks at starting a patient on osimertinib, and then at 4 weeks, we draw, you know, a ctDNA to see if there is the EGFR mutation still floating around in their bloodstream. If it's still floating around in their bloodstream, they stay on the study and they are randomized, meaning we don't pick, the computer picks, for them to get either osimertinib alone or osimertinib plus chemo. And this is regardless if you have an EGFR exon 19 or 21 alteration. If at 4 weeks that, you know, your ctDNA is positive, you stay on study and you get randomized. If your ctDNA is negative, you stay on osimertinib. And the point of this study is specifically to find out what kind of feature might indicate that a patient needs more than just OC, right? So the thought is maybe if your ctDNA is still positive at 4 weeks, your cancer's a little bit more angry, and maybe you might benefit from more chemo added to the OC, or maybe you don't need it. So I try to put patients on this study and talk about it because I believe in it, and I think it may help us answer this exact question. That was long-winded, sorry.
No, that's great. And it's a great trial and really important information to get out of that trial for sure. So I'll switch over to Dr. Rose and ask, if you can think of sort of your ideal patient when you see the patients that might fit into each of these, you know, different categories, who would you choose to get osimertinib alone versus osimertinib plus chemo, plus, you know, maybe needing radiation? What would you say?
No, I cannot paint the ideal scenario for any of these, unfortunately, but that is because this is such a complicated space, but I'll do my best, Dr. Saxena. So, you know, the way that I break down these different options is, of course, I think Dr. Prishigul gave us the first answer for sure, is a clinical trial. If we can learn something new to help our patients, that's the right way to do it. I also love that Shedders trial. I think that concept's really important across different paradigms in lung cancer, including immunotherapy, not just targeted therapies. So a clinical trial that's going to help us learn anything. But for the standard of care options we have right now, I still love the idea of just single agent osimertinib. We all celebrated having an option like this, having a pill that somebody can take once a day, and we want to be the future like blood pressure. You take your cancer pill once a day, and we're going to be able to control this for a long time. We're not quite there yet, but it's really nice to be able to plug and play a relatively tolerable pill that can work for a long time. But there are some people who deserve more. I really think that the chemotherapy trial, the Flaura 2, calls out the CNS disease patients. I'm not certain why they did much better on that arm, but it's pretty clear to me that patients who presented with brain metastasis from their lung cancer had a really significant benefit on that trial. It may be that having brain metastasis is just a predictor of a bad behaving disease where we need something stronger like chemotherapy. It may mean that because the disease has already spread to the brain, that there are sort of holes in your blood-brain barrier that chemotherapy can get through better and maybe is more effective. Whatever it is, I think that is the best time to have that kind of shared decision making with your patient, but you should really offer this to everybody as an option. But I think many patients are happy to jump off the chemotherapy wagon and be on the targeted therapy wagon. And I'll put in the plug to say, chemotherapy does not have to be a long haul. The study did have you do 4 cycles of chemotherapy followed by maintenance therapy. That may be too much. So I think you can split the difference and do some therapy up front and then let that person ride the better tolerable therapy after that, and you can still potentially reintroduce chemotherapy in the future. We haven't touched too much on the drug amivantamab with chemotherapy. This is another drug that hits on a couple of different targets, including EGFR and another target called MET. Amivantamab is a really intriguing molecule. It does have some benefits similar to osimertinib, but unfortunately, I'm a little bit more concerned about the side effects of this therapy. So I'm less excited about using amivantamab with chemotherapy up front, but potentially with a patient who has an EGFR plus a MET mutation where you want to leverage that drug in that specific scenario. I think that's interesting, but I like saving amivantamab for later. Any of the above with whole brain radiation therapy will never be my answer. I'm never favoring whole brain radiation therapy if I can. Unfortunately, this is an intervention that is sometimes necessary, but is almost always full of side effects and quality of life impacting results. So we use it when we need to, but if not, we have drugs that hit through the blood-brain barrier like osimertinib. We have focused radiation therapies with stereotactic radiosurgery and similar interventions. And we have great neurosurgeons who can pluck out brain mets like in their sleep these days. So if we can avoid whole brain radiation therapy, we do it. But again, if you can, clinical trial. We want to make the future brighter.
Great answers. So just to kind of take home and give the sort of conclusions. So the Flaura 2 study showed that, again, progression-free survival was significantly longer in the osimertinib chemotherapy group compared to the osimertinib group with a hazard ratio of 0.62. And at 24 months, about 57% of patients in the osimertinib chemotherapy group versus 41% in the osimertinib group were alive and progression-free. One thing I think we didn't discuss up until now is everything we're talking about is progression-free survival. We don't have mature data on overall survival. So does this actually make you live longer? To start with the combination of osimertinib and chemotherapy, there's some trending toward maybe it will, and maybe specifically for the CNS patients. But for right now, we don't have really full mature data on that. So that's also something to take into account. So we can't say for sure that if you combine the chemo and osimertinib up front for everybody, you have a better chance of actually living longer versus doing them, say, sequentially.